I think we're going to get started. I'm sure we're going to have people still trickle into this, and we have several dialing in remotely. I think we have several of the folks from West Virginia. But I want to welcome everyone to this first inaugural meeting for Value-Based Care Center of Excellence. It's really exciting to have the kind of turnout that we're having right now, and I think I'm really excited to have the levels of discussions that we're going to have. James Pat. I'm the President and CEO of Insight Health Systems. I've spent the last 25 years working through information sharing efforts across different verticals. So I started in the financial services world, spent a lot of time working with Global 100 companies with their business and e-commerce. About 10 years working, solving problems with national security. It really is complex and difficult and challenges. Started Insight in 2013. Really goal to basically help operationalize and optimize this trend to value-based care. We have great participants in here, and it's a pretty full room. So I think that maybe we'll just start maybe on this side and introduce yourself and who you're with, and go down the line, and then afterwards I'll pass the baton over to the folks in West Virginia, and you can introduce yourselves as well.
Sure. I'm Connor. I'm the Economic Development Director for the City of Dublin.
I'm the Economic Development Director for the law firm Ice Miller LLC.
You're the City of Dublin Economic Development. I have development because everyone else. John Overley, I'm a partner with the law firm of Ice Miller. We have the pleasure of representing Insight, also the City of Dublin, project firm for 15 years, and looking through issues and help. That's a great turnout.
I'm with Ohio University in charge of healthcare initiatives on City of Englewood.
And I was an economic development.
Great job.
I'm Lee Boyd. I'm with the Pharmacists Association. I'm Executive Director. I am Compliance Officer for Insight Health Systems. I'm here with Vicast and of the Chief Information Officer.
Health Sciences and Professions at Ohio University.
I'm Mark, School of Leadership and Public Affairs at Ohio University.
University of Tech Growth Ohio, which is our version of Rev1 Ventures or Jumpstart. You might be familiar with the Frontier program. And also run the Center for Entrepreneurship, which is a partnership between our public affairs and the College of Business.
Our group, and I'm here representing the Ohio Optometric Association.
Awesome Solutions. We're partners with Phoenix Health Lab, so we are contributing a little bit later.
Hi, I'm Grace from Insight Health. I'm the Vice President of Provider Solutions. I'm with Insight Health Systems. I'm the Business Development Coordinator.
The folks at WebEx, start, I guess, Arnie, introduce yourself, please.
West Virginia School of Osteopathic Medicine.
Well, Campbell.
With the West Virginia Health Improvement Institute.
You want to introduce yourself?
Yep. CEO for the Robert C. Byrd Clinic, the FEMI practice plan for the West Virginia School of Osteopathic Medicine.
And I think with Jeremiah.
Yeah, Maya Samples. I'm the Deputy Secretary for the West Virginia Department of Health and Human Resources. I oversee Medicaid, CHIP, and our Bureau for Public Health.
Thanks. Is it on the WebEx at this point? Are you on the call at this point? No. other folks that will be joining us as well. But again, really thrilled with this initial turnout. I know we're going to try to make this very succinct and have some follow-up items, but the agenda on screen right now. I'm going to work through this pretty diligently. The goal here is to make this collaborative, obviously, right? Any discussions, any comments, any editorials that you have, please let's try to make this discussion very fruitful for everyone. But why are so obviously the U.S. healthcare system is going through this major transformation, right? From this fragmented care, volume-based model to value-based care, patient-centered, coordinated care model. And there's a lot of reasons for the need to move to this. I mean, when you look at the spend in the U.S. right now, there's like $80 billion a year needed because of the current fragmented care system. The U.S., compared to other countries, we spend more per patient for the qualities pretty comparative to other countries. I don't think anyone can argue the need to make this transformation happen. And with this transformation to value-based care, there's new requirements. So we call this the new normal of health care. Traditional, the pay-for-volume model where the reimbursements are very different. Hi, Randy. Reimbursement models are very different. How providers need to track quality measurement to get paid, and everything. The whole landscape is rapidly changing. There's new requirements today for value-based care that we didn't have 10 years ago. What's important is because value-based care is line, and these are new requirements, it effectively operationalize this movement to value-based care, right? We're not going to get there by relying on things in the past, right? We get to value-based care by relying on EO systems that were designed to support the requirements 10 years ago versus what the requirements are today for value-based care. We're there based on the mindset of being competition and isolation. It's on collaboration at this point, right? Look at the objectives for value-based care. Important now is, again, there's new requirements of care, and ultimately it's around multi-user interoperability of information. And when we talk about interoperability, it extends beyond what we traditionally have thought of interoperability, which, today a lot of folks think, well, I've got one EMR system, they need to talk with another EMR system. That's certainly interoperability, but to truly operationalize value-based care, we have to redefine that. Interoperability now is more than just EMR to EMR integration. We have a high-risk patient that has a care team of providers, and some providers belong to very large, sophisticated health systems, but some providers may be small, dietitians or chiropractors, dentists, optometrists, pharmacies, whatever it might be, and very different levels of technical sophistication and systems in place. So the move to interoperability to value-based care is sharing information from system to system, sharing between different levels of technical sophistication and users, right? How to have a chiropractor that doesn't have a system affect information with a hospital system that has a very sophisticated system that's part of this, right? In redefining interoperability, it's beyond, all the factors that help us identify the true risks and the true needs of a patient. Right? The thing with value-based care is identify where the high-risk potential lost patients are. Be proactive and preventative to prevent them from the hospital. Let's spend a little time up front to, again, be preventative and eliminate or alleviate those costs. So identifying the high-risk, high-cost patients, you have to look beyond the information. Right? That might make up, 10, 20% of the health determinants, but you also have to look at the determinants, the environmental determinants, the behavioral determinants. Right? The challenge with transformation to value-based care is all that has to be true. And we call it the new normal of healthcare because everything in healthcare today, their business they have to be re-engineered, right? If you're a primary care physician, a specialist, if you're a pharmacy, if you're, a lab, if you're an HIT vendor, right, is trying to re-engineer their business to basically support this movement to value-based care. Major undertaking, and obviously the challenges are several. Talk about the challenges around the interoperability side of it, and what's happening now is there's a lot of buzzwords around value-based care, right? So you'll hear center medical homes, you'll hear accountable care organization, an episode of population management, referral management, and the list goes on and on and on and on, right? So there's a lot of these buzzwords floating, which, again, helps, provide some direction, but helps provide noise, right? I think that for, different stakeholders in the care continuum, what does this really mean, right? Pieces of this, do we really need to operationalize this? How do we do this? There's more questions today than answers at this point, okay? So that's a challenge. Where we want to end up, I think we know, right? In this case, this is a nationwide interoperability roadmap. So, a big picture, we know that ultimately this is going to end up, right? We're here today. The goal is to basically collaborative learning system, right? Bottom right-hand corner, collaborative learning system, again, you've got to deal with everything that I just mentioned, the inability across platforms, understanding the health determinants and so forth. So the roadmap, where we want to end up is there. This also highlights some of the challenges today, right? So that there's been a big push for EMR systems, and there's a lot that are in place right now, but there's still a lack of true information sharing that's part of that. So this is where we want to end up. This highlights some of the issues and challenges at the national level. At the state level, again, the states now have spent a lot of time over the last several years to try to put together their innovation health transformation strategies. Right? States have, state innovation model grants, both design perspective and now from an implementation perspective. And on here, again, is at the state level, at Ohio perspective, obviously specific objectives to transform to value-based care over the next 4 years. And identified is to do this effectively, all these things on the screen have to be figured out, right? To effectively do this, we have to address rewarding value, performance transparency. We have to address care coordination and efficiency at the practice level. Address non-clinical and clinical decision support. Engagement is a key aspect of it, right? Again, there's been a lot of work and effort to say these critical components for us to transform our healthcare system to be value-based care, all this stuff has to be figured out, okay? Different stakeholders are at different levels of figuring this out, right? So there's some states where, again, they've been through the design grant, the implementation. There's some states that just got their design grant, right? The challenge is how do we basically collectively, how we collaborate so that we move towards this together. We're not, different stakeholders aren't looking at what do I need to do to build a coordination system for value-based care, because by definition, it should be a system that connects and coordinates care across stakeholders. How do we allow, again, with the limited resources that everyone has, how do we provide mechanisms so that we're not trying to recreate the wheel every time. We can learn from past experiences of others, and we collaborate together to kind of advance this, because as I say, everyone has to figure this out. Independently, we're never going to get there, right? So, and my background, this is very close because it's deja vu. Again, prior to this, we spent a lot of time in security space, and the same complexity, same challenges that we're seeing now, we're here. And the only way we could basically break down the silos, drive coordination, is for this kind of effort to take place. So this isn't a question that this value-based care center of excellence can be successful and can help move the needle. It's proven, again, now it's just a matter of doing it and getting it done. To, again, the value-based care center of excellence, and what's the objective and what's the intent, and how to move things forward, right? So what we've already said was that this care impacts everyone, right? It's everyone from the payers to the hospitals, to the primary care physicians, to the allied health professionals, to the pharmacies and the IT vendors, and everyone that's in the healthcare space today. It impacts everyone. Okay, is that there has to be a level of collaboration to, take a high-risk patient, and all of us in this room care about being active and preventative to prevent that high-risk patient that we all share. How can we do to keep them healthy, costs, improve quality, right? We're only going to do that through collaboration. So the Center of Excellence, a goal for this is to become a shared facility, okay? Not a facility that lobbies to any individual stakeholder's perspective, right? Very, very important, right? It isn't about, I'm going to try to promote the interests of the payer, or promote the interests of a primary care physician, or promote the interests of a specific vendor, right? It's about having a shared facility that provides leadership, best practices, research, support, training, and collaboration, this cross-sectional interdisciplinary teams to be formed to collectively collaborate on how they can solve some of these problems, right? What technology and what kind of interoperability, what kind of patient engagement and provider engagement, we kind of build this together. So that's the goal for the Center of Excellence, is to basically be a neutral facility so that different stakeholders can come together and find where can we start, right? Right now, what happens is that, in most cases, because of the way that the environment is right now, is they don't know much about the other stakeholders. So the first impression is it's competitive. So data, let's keep the information close to the vest. What it takes is finding, you can't boil the ocean, you can't change things overnight. You have to find an easy common ground. Where's a fig leaf that this is where we're going to start, right? And then we start someplace that's not threatening to everybody. They expand on that collaboration, and that's going to take place. So that's the goal for this Center of Excellence. Is again, shared leadership, shared facility. We collaborate, build teams. Teams are, again, cross-sectional, cross-functional. As a build-out solution, it's a viable solution that can be repeated over and over again, okay? So it's the vision. Again, the mission here, again, as stated, is the ability to foster and facilitate the creation of these cross-organizational interdisciplinary working groups. These working groups can basically identify a topic and a problem statement, and the teams work collectively together to figure out how this could be best addressed. There's the solutions that can be demonstrated to everyone else, best practices that can be recommended. And now everyone's not recreating the wheel. They can learn from everyone else's experiences. Yeah. So goals of the Center of Excellence are listed here. So the first one is, again, provide leadership for the industry in advancing value-based care initiatives. About this, even this first meeting, and there was a lot of prep time for everybody, but it's really exciting to see that today we've got representatives from state levels, from city economic development. We've got payers, we got providers, we got a lot of associations representing federally qualified health centers, represent the pharmacies, represent optometrists, our vendors that are here at the table as well. That, just even from a starting point, we're a cross-sectional group, and the goal is to provide leadership for advancing value-based care. Together, we can provide tangible and demonstrable solutions and best practices. Enhance collaboration between stakeholders, provide clear and compelling value to all of the members. Right? So, and we're not lobbying for one interest over another interest. Anyone who participates in this, they have to be able to define what I get out of this and what's my value. So that's that big aspect of this. And is to track all the healthcare stakeholders that come together to solve this issue. Right? We can attract them all, and part of this is ensure that the resources required to keep this effort going, the collaboration to work through these issues, that they're necessary resources that that can be maintained, human and financial perspective, and achieve significant social impact through care initiatives. Okay, so this is what we kind of laid out as strategic goals. I want to pause here for a second because should have received some handouts. The folks in West Virginia that are remote probably don't have copies. I'll send this. And this is a starting point for discussion. The thing I'm saying right now is a fine starting point that we're hoping to get feedback from everyone. Right? So if there are certain things that you're going to hear today that you strongly agree with, if there are certain things that you hear today that you don't agree with, let us know. Right? Certain topics that you think we need to enhance, modify, or we need to edit, let us know. Right? Purpose of the presentation is to have a starting point. Right? It really isn't the ending point. It's a starting for discussion. Make that clear. And in the handouts, you can, for each of these sections we're talking about, you can say, this is something that I think you're right on point with, or, modify this, or I disagree with these points. And what we're going to do is we're going to collect all of this feedback. We're going to pass all, send up the summary of it to everyone. And we have another meeting that's set, I think, the second week of and we'll kind of go through this together. Okay, so pause to say this is the first draft of Center of Excellence. Okay. Quality, right? So if we're putting together these cross-sectional interdisciplinary working groups, the deliverables have to be high quality, right? The ability to work through technical issues and come up with solutions, to recommend best practices and protocols for overcoming some of these issues, the deliverables have to be of high quality, right? And again, we ensure that will be the case by participation from everyone here, right? Ensure that there's a lot of checks and balances here, and everyone has a seat at the table. Over and over and over again, that's going to be the common theme. Innovation, right? We innovate how we're doing things. We've got to innovate the technology. We've got to clearly identify here's the gap, and how are we going to solve this? Because part of this is to drive R&D, right? Is to drive solutions and drive partnerships and drive collaboration so they can meet what the current gaps are. There's a lot of gaps today to make this happen, right? Part of this is to identify what's there, where there's not, and how we, innovation to solve these issues. Resourcefulness, fiscal responsibility, respect, integrity, social consciousness. those are what we listed as guiding principles. Again, we're welcoming feedback to see do we missing something here? We need to monitor this. And then from the strategic areas, from the Center of Excellence, the level, I really summarize this 3. Okay, the first is from a growth perspective, being able to, again, organize this, being able to identify topics of interest, being able to develop working committees where they collectively can work through the process to identify where the gaps are, what the solutions are. Being able to take that and run this outside of just those participating today to, again, all the other stakeholders should be in this meeting today but aren't, right? It's really, really important. And I'll talk about the proposed membership model and what we use, again, in the national security space, again, as a starting point. But again, membership, how do we basically take the vision and the mission of this excellence? How do we all work together to basically expand on this, right? So membership and then funding is the other aspect of it. And again, it talks about, how can we fund our collective efforts? How provide a platform so that everyone can take their dollars they've got, take their resource, and get tests from it, right? Do that through these collaborative type centers. I've listed strategic areas and strategic focuses for the Center of Excellence. As far as participants' scope, anyone in the healthcare continuum today is going to be, right? Whether it's the members specifically that I've identified here are the payers, the health systems, primary care physicians, allied health professionals, physician providers, organizations, researchers, associations, right? There's associations for patient advocacy groups, there's disease-specific associations, the IT vendors, the labs, the pharmacies. Today, high-risk patient, either directly or indirectly during the journey, be open to be a member as part of it. Partners, right? This can be, again, the universities. Partnerships can be the state and the local agencies. The other, there's a lot of great industry advocacy groups and efforts moving forward already, like the health information exchanges across different states, right? Those great efforts. Now it's just how, again, we're certainly not competing with those efforts. It's tie those together, identify where the gaps are, collectively work together to basically strengthen and improve what those gaps are. From a partner side, any of these collaboratives or health information exchanges, account organizations can be partners of this as well. Supporter side, you talk about where we think we can get the support from a funding side. I think it's largely going to be from grants, endowments, from donations, and there's a lot of groups out here that want to make this a reality. A lot of funding that's out there. To be able to have a coordinated effort like this, both more easily some of that. Then member dues is another aspect of that I'm going to touch on. Okay. Get into the organization aspect of it. Just want to kind of pause and see if is there any questions or comments or thoughts about what you've heard up to this point? Track to do something pretty exciting? I'm either doing a good job or a really bad job. Okay.
James, you talked about just start the discussion a little bit.
Yeah.
There's a lot of key people in the room that you've listed, that the people who be members are people who will state's going to play a role. They care about this. The state's doing other things, and they can use this as a tool to help them achieve some of the goals. You know, the state has seen, I think, reduction in Medicaid spending. I think it's $2 billion for the current years that it's been progress, but they need help. How can this group, and maybe it's later discussion, help this effort reach out to the state to get them involved, or other private sector, or other, you know, we've got the pharmacy association here, we've got the Platinum Association, who else would be in the room, and maybe a discussion point now, but I think that's a good takeaway, because there's so much to this approach.
Yeah, and once I start talking about the working group and what the approach is, it's going to help answer that. I think one of the key tenets is that all the efforts right now we call boil. Spend a bunch of time and effort to basically figure out all the issues and try to build a solution that meets all these exceptions versus do to basically improve where we are today, right? Let's take steps versus let's do this big bang approach. And when I talk about these working committees and the process for, the goal isn't to start to change, eat the elephant in one bite, right? It's let's pick a small topic. Let's pick a very specific topic, and I've got examples I'll talk through here at the end. But let's have one small starting point, and following that patient journey, who's impacted during that patient journey, and change the world in one city, bite by bite. So I think when we talk about the working cases and the process for that, we can't boil the ocean. If we have no information sharing today, right, even something that isn't term as efficient as we want it to be, it's a step forward. We're moving forward. That the goal and the opportunity with this Value-Based Care Center of Excellence is that we drive change at a much faster pace than other efforts, because the other efforts have been boil the ocean mentality, right? If you look at all the development methodologies, the agile development methodologies, the iterative design methodologies, that's been proven over and over again to be successful. Here, right? So we'll get to that. Comments? So from a structure side, ideally, and again, this is a starting point for discussion. So I would love to hear everyone's feedback as part of this. The Value-Based Care Center of Excellence will be a separate state group, an organization, right? For a lot of different folks, Alex Miller here right now, we can explore a lot of different options on how to structure this organizationally. Setting this up as a not-for-profit organization is probably going to be the key, and what we did in the national security side is we set that up. But exploring what the different options are for this is going to be an aspect of it. Would be a board level, and the board could be made up of, what I've experienced in the past is, start off with as small as 3, and it can be up to 20, 25 individuals, because the members that make up this effort on the board, right? And the board members would be elected by the members here. So the board is a great cross section of the stakeholders here. Okay. There will be an executive committee for the Center of Excellence, right? And it's so the typical structure: the president, the vice president, treasurer, secretary. But then largely what this is this group is a facilitator, right? So when we talk about the work groups here at the bottom, those work groups have to be managed and facilitated, right? And that's going to be part of this group. So board, executive committee, initially, and obviously this will grow as we go. 3 committees: a membership committee, to basically kind of expand how we can get the word out and drive membership. Committee to explore different ways we can fund this through membership dues or endowments or donations. Work groups, and that's really the key, is the work groups. That's where the important stuff gets done at the group level. And each group would have a chairperson. Each chairperson would be supported by a project manager from the Center of Excellence. So it's a consistent way that all of these projects are looked at, is documented, and moved forward, right? So we're recreating the wheel at this point. There's some conflict between that. Work groups could be made up of multiple working committee members. And again, cross-sectional, interdisciplinary makeup of groups. And depending on the topic, those would be, five working team that over a 2-week period, or a group that has 30 people that last over a 2-year period, right? And so these working groups, again, what's going to happen is that each working group starts with a specific topic, and there's a lot of that grow off these things. That's going to be really important. So an overall structure, this is kind of what we've worked with past. We know it works very well. Again, it's a starting point for here, and we're looking forward to hear everyone's ideas and suggestions as part of this. To get this started, obviously, there has to be collaboration to form this piece of it, right? Right now, we have a lot of needs, right? As far as, board representation, executive committee representation, folks that want to basically recommend topics or chair topics. If you want to be part of a working committee, if you want to, help chair or promote either a membership or funding committee, there's a lot of needs to get this to happen. So again, one of the things we're looking for here is for everyone to basically think through this and see, this is where interest for me. This is to play the level I'd like to play in, right? Just continuously grow and grow and grow and enhance. So we've got balls at the top of the mountain. We need to push that thing off that snow cap, and as it rolls down, we'll get bigger and bigger and bigger. That's where we are at this point. Starting point discussion, and we're looking for your participation, right? And if there's again folks that aren't here that want to recommend and should be part of this, invite the next meeting. Get them here. We can. Everything here is recorded. All the materials are going to be available on a site where everyone can get access to it. So kind of fill this from an interim perspective as quickly as possible.
I'm curious about the scope. Obviously, West Virginia is with us here. Are you thinking of this as a national effort or regional, or just curious what the scope is?
Yeah, I think that having, the whole country is faced with the same issues and challenges, right? If you look at just the State Innovation Model Grant, right? All fortunate to basically get their design grant, work through that up front. Now we're in the implementation. A lot of these now we're getting their design grants. So again, how do we, is there an opportunity to make this national scale? I think absolutely there is. Trying to solve aren't just problems in West Virginia. I'm not sure or not. John McCormick is the Association of Physician ACOs, so it's 30 ACOs across the country. Okay, faced with the same issues and the same challenges. So I think that we want to start where we make an impact. We can start here would make an impact, but I think very quickly what's going to happen is this is going to be a national effort. Okay. Structure from a membership side, again, this is proposed. What I'm accustomed to is we have really 3 levels of membership. The base level we call as an associate member. Okay, we don't want to do is exclude anyone, all right? Include everyone, and individuals can participate. The associate members, and again, we can define this. What I'm to is those of non-profits or not-for-profit associations, been government agencies. Those have been students. Those have been, folks that that want to participate. They're interested parties. Get their feedback. Let them observe. That's an important thing. Associate members, at this level, there's no cost, no charge. Okay, we include anyone, but there's limits to their involvement as well, right? So an associate member be on the board. They can't chair a working committee. They can't do some things that we can kind of discuss. So that's our structure. The bulk of this is going to be membership driven, right? It can be for anyone, individual, corporation, company. It doesn't if it's a practitioner or a hospital or whatever it is, or a lab. It's based on news. And lowest level, we had $1,500 at the high annual dues. At the high, we had $7,500 annual dues. Again, starting point for discussion. But again, this is what we've been accustomed to before. Again, it's relatively a small amount to participate. We have to do some financial assessments around this, but with your space, a small amount of this can help sustain the Center of Excellence for the future. And then part of membership is the sustaining members. So the sustaining members are for those corporations that really want to show their deep commitment to their transformation. Show their deep commitment to annual of $18,000 per year. And the large companies, that's nothing, right? But again, the goal is that any of these large organizations or anyone that wants to show their deep commitment to this will be part of this. If it's a payer, if it's a HIT vendor, whatever it might be, it can be the case. So this is before associate member, sustaining member. Varying levels of contributions, varying levels of capabilities and benefits. Obviously, just the members would be part of the board and support, be part of the executive team, support, some of the working groups as well. Any questions or comments or thoughts around this current structure? No. We're going through this. Again, we're looking for folks to help on the membership committee piece of it. Right? From a work piece, basically help define, what the membership models can and should look like, evaluate this, come back, make recommendations to the group at the next meeting. We think that there's several opportunities for funding, grants, foundations, contributions, the membership fees that we talked about. Okay? And then the last one is service contracts. And found out at this in the national security side was since we're building best practices and since we're building viable solutions, there's other folks across the country that are facing the same issues and challenges. Right? There's an opportunity for organizations to basically come to the center and say, I do this project. And since you have this cross-sectional, group working together and you have this process working together, can I do the topic? Can we use our resources to basically fund this effort? And things we saw, again, that wasn't part of the initial plan, but it certainly became a very strong reality because what happens in these collaborations have working teams that are working together, right? An outside group can say, I've got, this requirement, and, instead of us trying to recreate this stuff, let's, investment here. You guys put this out. Any of the members can help work together to satisfy those requirements. So again, I think long-term, we're going to see that happening. Near-term, that's not going to be a strong part for the funding, but long-term, I've seen this happen before. Okay. And really the meat of it is the working committee process. The process that we're recommending is really a three-part process: inception, form, and execution. Right? Inception perspective, you have the members, okay, propose a topic or problem solution or statement. One can say, I've got here I'm a pharmacy and I want to be part of a PCMH model, or I'm an FQHC and I want to optimize the incentive for this chronic care management initiative, whatever it might be, right? So we recommend a topic here. Be brought, be sized and distributed to all members. Right? Basically, see what topics are being proposed. They can basically, determine interest level or rate their interest in participating, and basically be ranked. The members, as they provide their expressions of interest, they also say, hey, I will definitely want to be part of this. Or important, they don't want to be part of this, or share this group, or whatever it be. That's the goal. So then rank highest, then we can move on to the formation. And inside, those members have expressed interest, then can be, again, there would be a separate meeting that brings back topic and only express interest. And those members then the chairperson for that topic. Okay, determine who is part of that member team. Okay, recommended topic, those they can work together to identify someone that's going to lead the effort, and those are going to contribute to the effort. Okay, I mentioned earlier, each would have a project manager that's assigned by Center of Excellence. So again, is that there's a consistent way to manage projects, right? There's a consistent way to basically document the case studies. There's a consistent way to basically do recommendations to the best practices. But ultimately, all this stuff can be put into a knowledge repository that can help clinical, non-clinical decision support long term, right? To have that kind of a consistency across team members. And then this project manager helps basically just help facilitate the meetings, facilitate discussions, helps capture that information. We determine the appropriate team size, team makeup, and then the process, again, idea will be cross-functional, right? So before, whatever topic is, they can say, okay, for this topic, who are the stakeholders that are really touching this? Right, and reach out and get them involved, right? So it can be a different set of stakeholders. Side, the execution of this, right? So now we've got the project, the teams have been formed. Now we execute against this. And the teams would have a person and would have a project manager to be have meetings with the group to identify. What are the milestones that we're going to go after? How are we going to manage this? What frequency of our meetings? We're going to accomplish this, from a technical service perspective. And throughout that period of execution, the ultimate goal is to have a system that's demonstrable, right? The opportunity here is that in addition to this being a collaboration center, this is a shared demonstration center. And this is exciting because the vendors and all the different stakeholders that want to basically build their solutions to basically meet needs. Now they case those needs. And this happened before where it's an impetus where you have a handful of vendors like the early EMR vendors that say we know how we can demonstrate interoperability. We can incorporate clinical, non-clinical decision support. We want can integrate behavioral with clinical information sets, whatever it might be, right? A platform to actually showcase that. And you talk about, is this a local effort? What we found is that people across the country will want to come to that demonstration capability center and see it working, see things in action, okay? Usually what happens is that drives, those are demonstrating the capabilities, that drives piece towards them, okay? So I think that's an important piece of it. And quite frankly, what we've seen as well is that they can help drive funding agencies, whether it's federal agencies or state agencies, to say, anyone who received part of this grant, here's the way we want to see implemented, right? So this could actually become staples for driving grants and uniformity, across this piece. So at the end of this, the goal is to have a solution that's demonstrable. Again, the capabilities that will be captured in a consistent fashion, the best practices, all part of a knowledge repository. Any stakeholders, any of the members can leverage that knowledge repository for their own R&D efforts, their own causes, their initiatives, whatever it might be. Okay. This process. Man, you guys.
Do you have some sense of, at least in the initial phase, how many work groups you see forming? Or
I think a big part of this is, I think what's going to happen is once we get people topics, I think that we can kind of see where there's a lot of intersection as far as common topics, and then to how big of a group we have and what kind of resources we have to basically pursue those is how fast we can do that.
sort of infrastructure to support the work groups.
Right. Yeah, so we'll have to have some project managers. We'll have to have what that might be. So this is how this can work, okay, and work through it. And, a lot of it isn't hypothetical. I mean, we're kind of in process, and, we've been doing this as a company. We've been working with remote value-based care and work with for a while. And in cases, again, there's issues both from a technical, purpose, collaboration that always has to come together. Okay, the most technically advanced solution, but if you get the different stakeholders that have to come together, you're not going to move that effort forward. And the premise of this Center of Excellence is, right now it's kind of been like herding cats, right? I've got share information with this provider, and I rely on my EMR vendor to tell us how we can share the information with that vendor. I need to rely on my partner's EMR vendor to be able to figure out how they can bring information in. And all vendors, they have to put it on their own project timeline, and there's potential costs associated with it. And we've seen very, very simple requests, 6 to 8 months, to data critical to share information. It's ridiculous. It's just at the State of Ohio, where they have a 4-year objective to transform 85% of the practices. Guess what? That can get innovation that takes place, right? That's really important. So this is one example, okay? And Andy, I'd love to get your feedback on this, because we talked about this. Management, the PT 99490 code, okay? It's incredible. It's a very exciting incentive that's available for have patients that have 2 or more chronic illnesses. Okay, structured. It's on the fee schedules, right? Providers that have patients with 2 or more chronic illnesses, the incentive money is actually very, very rich, right? So depending on who there is, if it's a Medicare patient, it's $40 per patient per month. If it's Medicaid, it could be, $34. Commercial partners and are supporting this, and it's at $56, and this is a per patient per month incentive model. So this is really rich, right? So providers, optimizing just on this incentive payment, opportunity to increase their revenue by half, 2 times what they currently have. Just this benefits of improved patient quality, improved patient care, improved patient satisfaction. So this chronic care management incentive program, it's a great incentive. And some numbers out there where 3.5 million patients are eligible for this. I think less than 100,000 of them are incentives right now, being optimized at this point. So there's incentives that's on the table, providers aren't capitalizing on that, right? That for chronic care management, there's a process that has to be adhered to. There's technical requirements, procedural requirements, there's service requirements, activities requirements, billing requirements, payment requirements, and all it is that because early on, work through that process from start to finish, it's still out there, right? Discussions with right? We're going to reimburse the FQHCs for this. And, we want to kickstart this, and we're going to reimburse them at the payment rate, right? There's no way they can reimburse the payment rate. We went to the health center, the FQHC, they're saying, no, there's no way they can do this. How do we manage the process where we got patients that are on Medicaid? How do we manage this? So, again, the incentive is out there. To how to actually get this done, work in progress, right? So one of the first opportunities, I think, is this. This could be a great project that says to develop a working team that says we're going to, the OACHC and QHC, and then Dr. recommending has sort of said if we want to be happy to be the driver of this. There are actions with Ohio Medicaid. There are actions with the different EMR vendors that are supporting the different FQHCs. Right? Part of that is information stored in the certified EMR, right? Things that come together to work with the end-to-end process. Okay? So as a team, we can get that done very quickly. And that's one of the projects. And from here, again, there's a lot of arms and legs to this, right? This could be one work that basically says, let's create the end-to-end process flow for P99490 code, okay? I'll build on top of that. Here's one of the services requirements. We've heard this over and over and over again, right? Now, if you work with different things, they may have their own pocket of social services they recommend and refer their patients to. Okay? And I think the goal here is, if on number one, we have, patients that have 2 or more chronic illnesses. Okay, so first subgroup, we're going to say, here's the patients. Now, subcategorize those patients. Some of those patients have, below the poverty line. Some patients have not had a job for the last year, right? Patients have behavioral health or development disability issues. Some have diabetes. Some of these patients have heart disease, whatever it might be, right? So if you take each of those can be separate task forces and work groups. Do a needs assessment for a patient that is low income or below the poverty line. What is that needs assessment survey? What are the questions that we should ask, right? Based on understanding what the needs are, who are different social services that we can that patient now can be referred to, right? Talking out loud, if it's a that is has a job for 12 months, well, we know the risks are they probably can't afford medication, right? With service like the patient assistance programs where those patients can qualify and get medication at lower cost or no cost. We point. point, right? If they have a job for a long time, refer to food bank services, referring them to organizations to help them with resumes and finding jobs, right? All social services piece of it. One thing that we haven't seen is that there's a lot of organizations doing, creating momentum to help with specific efforts, right? Infant mortality is a big issue, right? Public health on their infant mortality issue. There's groups out there that independently have gone out and they said, we want to help solve this problem, and we're getting donations and funding. And one group specifically, they're taking donations and they're providing mothers of need of a crib that can't afford a crib. They're in the crib. Like, you have groups that are forming under everyone else out there. Right? To create a social service registry where anyone can basically register their services. I brought that up to Columbus Public. They weren't aware of that group was out there. So it's connecting dots in a lot of places. So I know just from discussions, this would be an excellent working group. That's what we assess the needs, how we centralize the social services that are available to them, and basically do the links, the referral management, so that here's the need, we can refer them to them.
Question, or add one more example. With the City of Dublin to write a grant for the Dublin patients to basically connect health and geriatric patients. And ViaQuest, you were part of writing this grant as well, but we weren't awarded the grant. I think the Centers of Excellence would be a good mechanism to do that work, but essentially the goal was connecting Dublin Springs Hospital with Dublin Methodist, with the ViaQuest, with the Dublin Rec Center, all of those different services that the same patient population was using in Dublin, but nothing connected, and so providers are not getting that holistic approach to healthcare for the patient population. So that's an example we might be able to do and leverage here.
So these examples, I know topics we've already kind of been floating. We already have several folks who are saying we want to be part of that team. We want to be part of that group. We be the guinea pig to basically put this stuff together. Again, these are two real examples that can kind of move right away. Another of this is mental health patient protocol. So again, from number one, let's identify here's an eligible patient because they have two or more chronic illnesses, and one of those chronic illnesses they've got developmental disabilities or mental illness, right? So as part of chronic care management, there are care services that have to be performed, right? To collect chronic care management, number one, 20 minutes to be spent on each of these high patients. If the coordinator is reaching out and spending 20 minutes with that higher patient, what's that 20 minutes, right? So a great opportunity is that, using this as an example, health, potentially with ViaQuest to say, or with state or other groups, NAMI or whatever it might be, to say, for a behavioral health patient, here's a protocol that's followed, things to measure, right? To have separate working groups to take a narrow slice of that. Right? With just number one, then into lots of groups, right? Working groups basically build the protocols and the patient protocols for diabetic, as hypertension, low poverty, whatever it might be. Each separate tracks, and again, the value here is that you have groups coming up recommending those protocols that is placed in a knowledge repository. The repository can be leveraged and repurposed over and over and over again. Okay. Real life examples that we're very intimate with, I'm sure there's a lot more of them, but that's an example, right? We could develop working teams, right? That's for a number of, who's critical, who's part of that working team. Well, we have some, Medicaid, the path to have to be at the table because everyone's defining, the process and the procedures, right? Obviously you have QHC, you have these EMR vendor, right? The HIT vendors supporting this. Those are critical stakeholders. So that for this to effectively be accomplished, we can develop those teams in numbers, which is really, really neat here because when we dealt with on the national security side, just like here in healthcare, a lot of different vendors, some of them have predominant share. So now you have, how we get this vendor that has predominant market share typically play easily with everyone else, where in many cases, it's called the 800-pound gorilla type mentality. We want to be the solution. So the nice about these efforts is that when there's strength in numbers, when there's groups come together, it's very easy for an EMR vendor or an HIT vendor to say, I don't participate. And what we see, and then it's exciting when you see this turning point, is that there's a point where there's going to be a lot of people that wants to be standoffish. But once you get the first leading, say, you know what, I understand that I'm not competing by holding data hostage. It's about interoperability. There's a turning point, and those vendors that aren't supporting open systems and interoperability, it's a competitive advantage at that point, right? Because this drives procurement. This drives a lot of things at that point. So we've seen this make a difference, and here's just some examples. If we everybody, I think everyone could probably recommend 2 or 5 or 10 other project tasks. And again, what we'll do is we'll organize them. We'll see where there's commonality, where there's overlap, and we can discuss at the next meeting. Okay. So yeah, we're actually doing really good on time. So our goal was to basically have for discussion to talk about what your next steps are. Any feedback you can provide here.
Started this, what's going on at the state level already to bring stakeholders in to care about today, to fix today? Is that in the logical direction?
Absolutely. Absolutely. Definitely would love to see that. I mean, like with Ohio, they have clear objectives and they've got the design models that they're completing right now, and to get the innovation and to get those things going, this could really help facilitate that. And I had a question with McKinsey. McKinsey will want to participate on the next call. The organization that's they won that state innovation grant. They're very interested in participating in this as well. Comments? Anyone in West Virginia? Your ideas or thoughts of what you're hearing? Some nice conversations about some of the things that you're doing and some cross just having with other states as well. Is that something you can touch on? And where you fit into this? Anyone over there? If you're talking.
Keep it down.
Yeah. Thanks.
Okay. I'll just say that I think you've already said, that the challenges are constricted state lines or in group. So I think you've done a good job of laying out the conflict that we all face. And West Virginia is in the design phase in terms of our SIM project. So a lot of the same issues, and I'll let Steve maybe identify practical considerations.
From our perspective, in being involved, both from learning how others are trying to solve the situation, and also provide back on how it at the practice level. It's something that teaches us every day. Value-based payments and payers are progressing quickly to 2017, 2018 different models. We're engaged in 4 contracts based for performance contracts, and all 4 of those operate differently. So, ideas on how we can do it at a state level, how we can make it more efficient, we can make it meaningful, love to be part of the process.
Wonderful. Thanks, Steve. On the call here, I'm real excited, to work with our university on this. I think that, there's so much focus on transferable practices, right? So all these practices today, the focus, we've been doing things forever. Now we've got to do things differently, and we've got to figure out how we're going to transform that practice. And there's a lot of time, there's a lot of focus on that, right? The whole state grant is on that, right? How we move that. Is that in addition, concurrent with that, this is a normal health care. So in anyone that's a student that wants to be a physician, they have to be trained on new normal of healthcare, right? It can drive change behavior, it can drive so and we have to look at it from both sides of that. How do we do the folks that are here do it a certain way? How do we help transform? But how do we help prepare folks that are coming into the space, the right education, the right tools, and the right mindset to make the decisions, right? Like their coordination, that's a huge opportunity, right? So those folks go into school saying, I'm to identify where I want to take my career, right? Opportunity around nursing and care coordination, care services. Primary, my whole family's in medicine. My dad's a primary care physician, my brother's a primary care physician, and so forth. And, we've had endless conversations about how, the primary care physicians, PCP, they're working hard as other specialists, and they make a lot less, right? And, and we've been doing value-based care forever. We just haven't been paid for these things forever, right? That, hey, some of these models, like the patient-centered medical home model, or the chronic management model, can significantly impact that. So your income is at par with everyone else. That determination, there are determining, what area especially do I go into based on income levels. They're going to want to see these kind of things, right? Some real neat opportunities, working with the universities, working with the government agencies, working with everyone in this room trying to make some of these things happen. And again, it's a the opportunity list, right? We can look forward, how we can transform practices. We can start with a payer perspective. We can start wherever you start. I always call it like like a pond. You drop a pebble in the pond, and the ripples meet all the edges. That's kind of what it is. So it's how many pebbles can we collectively drop in this pond? Quickly.
Last week we were at the OPC PCC conference, and there was a wonderful speaker from the MCA who basically how the Y is taking on this new mission of transforming into becoming a partner with the medical community. And maybe in your time as national solutions that were traditionally part of that conversation altogether and the transformations that made.
Huge, no question. I mean, you know, with when we within the national security side, had didn't share information with the local agencies. It's hard to believe that was the case, right? Agencies that want to share information with other local agencies, whole, you know, our job better than you can do our job better. And it was just a lot of non-technical issues in sharing, right? You know, post 911, there was an obvious need that we have to improve sharing for, you know, prevention, right? There wasn't any standard approaches, right? So, you know, Maricopa County in Arizona, right? They took grant in Maricopa County where they could share information with Maricopa County. Here in grant money from Department of Justice implemented a project to share information with Ohio. In Florida, they did the same. And guess what? You couldn't between them. You information between them. There wasn't any, you know, there's plenty of standards, right? So that's the issue. And there's lessons to be learned here, right? So because of that effort, they created a national interoperability standard and framework called the National Information Exchange Model, and all the substandards were mapped into that. And, you know, it took an effort like this to kind of tie this together, because I absolutely think and know for a fact, because I've had these discussions already, that we don't have to recreate the wheel either, right? At net security and what they've done, the same problems that the challenge we have now in healthcare, financial services. When you look at e-business and e-commerce of technology that's out, you know, again, one of the things I always use is that, you know, I have 10 different bank accounts, mutual funds, and insurance accounts, and I can go to a program like Mint.com and register all my portals and have one portal that has all the data across those systems, right? Now, in healthcare, you know, a high-risk patient that has 4 different providers, and people use all those providers have stood up a patient portal. From a patient perspective, I got 4 portals I've got to log into. You know, health information exchanges here in Ohio, and on the border, now I've got 2 in West Virginia Health, you know, WIN that we've got to share information with. That's already there, right? As a patient, I'm sure my portals have a unified portal. It's there. It's proven, right? We don't have to recreate the wheel anymore at that point. So I think that's great lessons that absolutely can be learned. Discussions again with the folks at the ICE Institute and those, and you know, about the possibilities of having one common approach for sharing to promote value-based care, but be that across with different justice. You know, every day you can open up the newspaper and say, hey, here's a patient that had mental illness, and you know, all these different signs, and enforcement should have known about those kind of things. So this cross information sharing, those are all opportunities this can take place. So I think what happened is, you know, this becomes known. We have a lot of stakeholders that want to leverage this. A lot of stakeholders that want to leverage this. And if it's done in a standard approach and standard methodology, then I think it can be leveraged. And that's a great thing.
And really what you're doing, a lot of efforts to create health information exchange that really dive into how can we alter practice. And I think that the biggest we've got is what you know, with the FBI and the other groups, that pharmacists in this silo, physicians operate in this silo, others do this. And in hospital, we do pretty good at playing together in the same sandbox and share physician times, all right, pharmacists to dose patient, depending on the values, we work together very closely. And, you know, I'm looking forward to this. I don't know most physicians realize that 1/3 of the scripts they write are never filled. And if the pharmacist were able to, when the patient comes in and says, I can't afford the copay, instead of that, contact the physician and say, we've we've got a problem here that's going pretty deep, because we've had patients that refuse their transplant drugs. The copay is so high that they'll take the other 8 drugs and don't do a thing to keep their transplant. That makes no sense. So I just see what we're able to do to try to get,
That's great.
world.
Thanks, Ray. Good. Comments or thoughts?
Can I ask a question to the group? Are there any glaring omissions from the representatives you've seen on the list that servers or folks participating in these meetings that considered for inclusion? A couple reached out to are going to be at the next meeting, Jobs Ohio, the Ohio Board of Regents is very interested in this. They've got a big conference. Groups you think we should consider that you don't see on this list?
I heard in Cincinnati a couple of days ago that was interesting, who works with the homeless, the Vestas system in Cincinnati that connects there. And it's a system set up to connect a person who comes into a shelter to hospitals. It's just fascinating how it took them about 10 years to pull it off, but when a homeless person walks into any system, even if it has the best system, they put the person's name up and know that the night before they stayed over at the shelter across the street, 5 ago they got food at the food bank. So there's probably 50 different organizations, but that was one that I think there's a lesson for us in the early stages.
Yeah.
EA.
Yeah, there's different groups, like Department of Health, they, a lot of population management data. We spoke with the ability to link that information in to these efforts. Critical, I think that population management being a big buzzword. I know the folks in West Virginia Health Improvement Institute spend a lot of time. A lot of the individual stakeholders here are spending a lot of time on population management. Again, there's being able to put together any of those things. The research databases that are prevalent. These research databases and systems now, where aggregate research information for cancer or for whatever these topics are. All things there's value. Again, when you look at the example with a chronic care patient, that can be in anything. Risk factors. What are the need factors? Who can we go to pull in information to help better either provide information or knowledge or provide services? I think it's endless,
So even a CMS, is there a CMS representative? Or is everybody in DC?
There's Chicago, that's NLSP.
What is it? Okay.
That's our region is.
Yeah.
Organizations that are represented here.
Yeah.
Physicians Association, Hospital Association.
Nursing.
Yeah. Okay.
We're not going to answer that question, but I think this is really interesting in terms of what you're doing. Our experience is we can help. We have some expertise in system innovation and systems development, which I think would fit nicely into this in terms of essentially a launch of new ideas as well as system innovation. We're, like everybody else, have some data capabilities. So I think the issue is to put all these together in what is a major venture for a lot of different kinds of issues. So we're very excited about this.
Appreciate that.
Thank you very much. The comment I make is that I want to leave the framework a little looser so we can further down the road in terms of how the thing works instead of locking in essentially all of the components of this.
Absolutely. That's a group. And again, I just want to reiterate, what I showed here was a starting point for discussion.
Okay.
So again, and I think we're actually going to just wrap this up now, is that there's feedback forms that everyone has. We're going to summarize everything we get, and we're going to send it out to everyone. And I love to hear those kind of comments. So again, appreciate your support. Good. So again, if you can take the time to give us your input and feedback, you either leave it here or email it over to us. We consolidate the information. Any thoughts or any topics that you want to talk about, for the meeting, we'll bring that together. Anyone that you think that, again, that isn't here, that should be here or could, we'll look for your help to basically continuously grow this. I mean, for the first meeting, I think it's been a phenomenal turnout. I appreciate everyone's help with that. If you can mark your calendars, our goal is that December 10th, Thursday, December 10th, our meeting. Okay, invites will be ideally 2 o'clock, and ideally here as well. I'm going to speak, but appreciate that. And, thank you so much for hosting this. This is very, very exciting to have your support on this. And again, I just want to thank everyone for your participation. This is very exciting. I think we can make some great things happen. Look forward.
Thank you.
Okay.
Appreciate it. Yeah, and start going out, moving along. Anytime either one. In my office. Okay. We're just gonna start at the Grand Park there at Board of Health. But it's getting better. My whole idea is 50% of people are drugs around. If we get them to take it right, here's say $4 for every $1 we can. Really, so we're getting a fair number, a lot more income on that rate. That makes a big difference. Hard to do with the country. Yeah. Either way, but we've got to chat with some new activities. Sounds good. I'm gonna package whatever I have. How you doing? Good. I'll take it out. Yeah. I think so. Anytime you want to, get together.